Chiranjeevi, a blessing for living a long life, is often the expression bestowed by elders in the family to young ones, more particularly children, and most importantly to a newly born baby. The moment of giving birth is the best moment for a woman. Every pregnant woman hopes for a healthy baby and an uncomplicated pregnancy. However, a considerable number of women die from problems related to pregnancy and childbirth. This includes adolescent girls who are victims of social causes such as child marriage and becoming mother before the childbearing age. India has the largest number of births per year. At the same time, the maternal and neonatal deaths are estimated at 1.17 lakhs and 11 lakhs per year respectively. When a mother dies, children lose their primary caregiver, communities are denied her paid and unpaid labor, and countries forego her contribution to economic and social development. A woman's death is more than a personal tragedy. It represents an enormous cost to her nation, her community, and her family. Any social and economic investment that has been made in her life is lost. Women experiencing complications during pregnancy leave their children with infections and disabilities. Large number of babies die soon after birth or within the very first month. The poor health of the mother, including diseases which were not treated before or during pregnancy, is a factor contributing to newborn deaths. The risk of childbearing for the mother and her baby can be greatly reduced if a woman is healthy and well nourished before becoming pregnant. She has regular maternity care by a trained health worker at least 4 times during every pregnancy. The birth is assisted by a skilled birth attendant such as a doctor, nurse, or a midwife. She and her baby have access to specialized care if there are complications, and she and her baby are checked regularly during the 24 hours after childbirth in the first week and again 6 weeks after giving birth. Gujarat is an economically well-off state in the country with estimated 18,000 registered doctors with about 2,000 gynecologists. Till 2005, the government tried to develop their own rural hospitals as first referral units, that is FRUs, under the CSSM and RCH program without much success. Most FRUs could not become functional due to lack of gynecologists and pediatricians in rural areas. Gujarat struggled for a very long time to manage the critical circumstances. Further, the families belonging to BPL and tribal population did not have sufficient financial resources to afford private medical service. The cost for seeking private medical care was prohibitive to the poor for seeking care during delivery. There are several reasons for high maternal mortality rate and infant mortality rate, such as non-availability of skilled midwifery services and skilled birth attendants or emergency obstetric and newborn care. The past efforts of providing EMOC services in rural areas have not succeeded because of unwillingness of gynecologists and obstetricians to work in rural areas. Some young people join the government services and government hospitals at sub-district level in rural areas, but after few years leave and start private practice and seek jobs in urban areas. To reduce maternal mortality rate and infant mortality rate, the government of Gujarat appointed trained traditional birth attendants in rural areas, but it did not make much impact. The problems were studied and it was found that there are 3 main reasons. The first being delay in decision making, that is whether to have delivery at home or take her to the hospital. It was a health-seeking behavior which prevented people to take immediate decision. The second reason for the delay was the total absence of transport facilities at this critical stage in and around the village. And the third and the foremost was the non-availability of gynecologists in rural areas, which was the main factor in taking a suitable decision. In 2005, The Gujarat government, in collaboration with academic institutions like IIM Ahmedabad, NGOs Seva Rural Jagadia, and facilitated by GTZ, started to explore various options to provide skilled care at delivery and EMOC through private sector. Gujarat has many private obgyns practicing in small towns and rural areas. Through a series of consultations with key stakeholders, the Government of Gujarat Health Department worked out a scheme of public-private partnership to contract private providers to provide delivery care to the poor in rural areas. This scheme was called Chiranjeevi Yojana, a local name meaning long life of mothers and babies, which became the flagship program serving the rural community in the most innovative manner, and the involvement of private practitioners paved the way for its success. The poor, as defined by the government, are families earning less than or equal to Rs 12,000 per annum or based on absences of certain household assets. They are commonly called as below poverty line families and are provided with an identification card called BPL card, which makes them eligible for several social welfare programs targeted for the poor. The former Health Commissioner of Gujarat government, Dr. Amarjeet Singh, has the privilege of being involved with Chiranjeevi Yojana since its inception.
A large number of obstetricians joined the scheme voluntarily, despite a very reasonable compensation. Out of the, I'm told, about 1800 obstetricians available in Gujarat, about 800 joined us initially. What you have to remember is, it's not only the money, but it is the scale. The state government was sending to them 500,000 deliveries. So it's a scale which mattered. And I believe some of the doctors earned upwards of 5 million rupees for the scheme, for taking part in the scheme. The other part which is critical is that the state government has to support the doctors. For example, we did 3 things. The first thing was a mechanism was put in place to ensure that the doctors were paid on time. There was no delay in payment. The second thing was that the doctors who signed the MOU were given an advance of Rs 25,000. The third thing is, we took full responsibility for all those patients, all those mothers who were referred under the scheme to the private obstetricians. This means if there was no negligence, the state government took full responsibility in terms of a legal case or any claim payment if unfortunately the mother died in the process of delivery. So the state government extended all support.
The Chiranjeevi Yojana was started in October 2005 on a pilot basis in 5 remote and less developed districts of the state. The scheme was launched as one-year pilot project in 5 districts of Gujarat: Banaskantha, Dahod, Kutch, Panchmahal, and Sabarkantha, with poor health indicators. Under the scheme, the health department empaneled and contracted private practicing obstetricians who had their own small hospitals in rural areas. Based on the successful experience of 1 year of the scheme, it was extended to all districts, covering the entire BPL population in January 2007.
The incidence of Chiranjeevi Yojana deliveries in my hospital is around 50%. That means out of 150 deliveries are by Chiranjeevi Yojana. Chiranjeevi Yojana is a boon to poor patients. The people who are villagers, who are illiterate and very poor, they are coming here for normal deliveries and operative delivery without any expense. No medicine charge or anesthesia or any drug charge. Total delivery and hospital stay with vehicle allowance is totally free. By Chiranjeevi Yojana, maternal mortality and fetal mortality is drastically reduced. No maternal mortality in my hospital since last 3 years out of Chiranjeevi patients.
To make sure that the panel of practitioners employed for the scheme is effective, certain norms have been formulated as a qualification for them. These norms stipulate that the doctor is at least a postgraduate in obstetrics. The doctor has his own hospital with a minimum of 15 beds with a labor and operating room. The hospital should have access to blood in case of an emergency and should be able to source anesthetics and surgeons to perform emergency surgery if required. The sterilization procedures in the hospital should be accredited for family planning by the government. Chiranjeevi agreement is executed between District Health Committee and the doctor or the hospital. The private obstetrician enrolled by the government for this scheme were to provide skilled care for delivery and comprehensive emergency obstetric and newborn care when required, free of cost in their own hospitals to poor women. In return, the government paid the doctor Rs 1,79,500 for 100 deliveries, including the handling of complications. It has been now raised to Rs 2,80,000 per 100 deliveries. The obstetricians are to pay the poor women Rs 200 for transportation and Rs 50 for the person accompanying the pregnant women to the hospital. An advance of Rs 25,000 is paid for this purpose to the doctors. This ensures that there is no constraint on the expectant mother or members of her family to reach such hospitals and avail the benefits of this grand scheme.
हेलो 108 हाँ मु बोलू आशा वर्कर हाँ बिलोड़ा तालुका थी रिंटोड़ा गामनी सु हाँ તમારી એક પ્રસૂતિ અને પ્રસૂતિ માટે લઈ જવાનું છે અને દુખાવો ઉપડ્યો છે એટલે લઈને જવાનું છે હા તો હા બિલોડાની ગાડી અત્યારે નહીં આવે ના હા તો કશું નહીં કે સાંભળાય ના કે હારું હારું વા રસ્તામાં જ ઘર છે હું ત્યાં જ છું.
EMRI, that is, the Emergency Management Research Institute's 108 service for immediate pre-hospitalization healthcare needs, is spreading its wings far and wide. Emergency care is delivered through a fleet of more than 400 ambulances made available in all the 26 districts of the state. EMRI is a non-profit organization based on the public-private partnership model, with around 95% of its funding coming from the central and the state governments. Launched by Chief Minister in the state, the service has so far attended to more than 11,000 emergencies and saved more than 1,000 lives in Gujarat. The pre-hospitalization emergency care provided by EMRI is free of cost, and the patient is admitted to a hospital of his or her own choice. More than 400 hospitals in the state have partnered with EMRI and have agreed to stabilize the patient brought in free of charge.
When we look into the matters and causes of maternal and neonatal mortality and morbidity, the roots basically lie into the antenatal care, intranatal care, postnatal care, and equally it has a bearing on the neonatal and newborn care. If we focus only into the intranatal care, we tend to miss out the antenatal care and postnatal care. To address all these issues and to reduce the maternal mortality and neonatal mortality, we need to have a comprehensive approach which addresses both the important aspects, both maternal and neonatal.
Health and Family Welfare Department of Gujarat has tremendous healthcare responsibilities. The department caters to health needs of nearly 160 lakh population of the ever-growing metropolis and has also to share the burden of migratory as well as floating population from neighbouring states, which constitutes nearly 33% of total intake at major hospitals in Gujarat. Welfare of each citizen is the aim of Family Welfare Department.
Majority have recognized the importance of this scheme. The benefit is a win-win situation for government as well as for private doctors and for the patients also.
This scheme empowers the poor in several ways. It provides them entitlement for free delivery care in private sector. It provides immediate access to EMOC when needed. It also provides them choice of several providers nearby which they can choose from.
I am one of the pediatrician of government yojana, that is Bal Sakha Yojana, which is it's carried out at Khiralu, Satlasana and Vadnagar. I am looking after all the 3 talukas and also the adjacent people of the nearby 3 districts, that is Banaskantha, Sabarkantha and Mehsana. I have facilities of all type of neonatal intensive care, including neonate ventilator and all these things. I also have an ambulance to tackle the patients of the adjacent centers like Vadnagar and Satlasana. I am being supported by the 6 gynecologists, out of them 1 from the Vadnagar, 2 from the Khiralu and 3 from the Satlasana.
Such schemes, which focus on involving private providers, help in addressing major human resources challenge in rural areas. It also shows that poor women who used to deliver at home will rapidly change their behavior if good quality services are accessible within a reasonable travel distance and at the same time creates less financial burden in accessing them.
चिरंजीवी योजना का मैंने फॉर्म भरा था, वो मैंने अर्षद भाई को बताया, डॉक्टर साहब को। उसने बोला कि तुम 100% BPL हो तो तुम्हारा पैसा नहीं होगा। तो मैंने सर को बहुत आजीज किया और उन्होंने पैसा लिया नहीं और मैं 100% लाभार्थी था और मेरे मिसेज का ऑपरेशन किया और बाबा का जन्म हुआ और बाबा भी तंदुरुस्त था। उसके 1 महीने तक वो रसी का भी कोई खर्च नहीं हुआ और मेरे बाबा भी तंदुरुस्त है और मेरी वाइफ भी तंदुरुस्त है।
The key message is that it may be more efficient to harness available skilled providers in private sector by paying their marginal costs plus reasonable profit rather than waiting for improvement in public services, which is very challenging in some developing countries like India. However, there are concerns that such schemes may not target the poor properly. Recent household survey of the scheme in one of the pilot districts suggests that most of the Chiranjeevi users had annual income levels less than Rs 12,000 per annum, indicating that the scheme was able to target the poor families. By involving the private healthcare providers and making rural areas attractive to these providers by assuring a minimum demand for services, the health markets in these areas also get developed.
Everything, all bottles, then there's this injections, and after going at home after 48 hours, all drugs, ointment, etc. are paid by that Chiranjeevi doctor. Patient has not to spend any single penny. At the same time, when patient is being discharged, in Bal Sakha Yojana is also there, adjoined with Chiranjeevi Yojana, and in Bal Sakha Yojana, all this pediatrician is having 2 visits. By chance, the kid is ill one, then patient is incubated in the hospital, and that all services are made free.
This has also implication for augmenting human resource in other areas of healthcare. Thus, it counteracts the pull of urban areas, which normally drains the private providers from rural areas to cities. By focusing on paying the private providers for each delivery done, the scheme envisages funding the outputs rather than inputs as it happens in a government system. This is much better way of linking the performance of the service delivery with payment system. The Chiranjeevi Yojana experience suggests that it may save lives and make economic sense to harness the energy